So today's session is on the HCBS settings rule in residential settings. So I am going to present, as I mentioned, the Disability Law Center. We've done several rounds of visits where we've gone out and talked to providers in residential and non-residential settings, but obviously for purposes of this session, we're only going to focus on the residential settings. So these are the requirements that the rule lays out for provider-owned and controlled residential settings. I don't want to spend a ton of time talking about them because I think it's probably best for me to talk about our survey results and what we found when we actually went out to Utah providers and talked to Utah consumers of HCBS services. But these are the requirements, and we can talk about them more later if you all want to. So, I think I mentioned that in March of 2016, the Disability Law Center published a report. It was called Evaluating Utah's Transition Process and Opportunity with Inclusion. And really our goal with this report was to go out and just kind of get a lay of the land, see what was going on, see how providers felt about the rule, how services were being delivered, and of course talk to consumers about their experience. As Elizabeth did a great job discussing in our opening session, the rule is really about the experience of the person receiving services, and so we felt like it was critical to talk to people receiving services and see what their experience was. So our survey initially included 11 providers in 13 different settings. Providers were randomly selected and included residential and non-residential providers. And then we also tried to make sure to have providers in both rural and urban settings. I think getting at, again, some of what we were talking earlier, that we know that there might be some variations or differences in what's available at different parts of the state. So we wanted to make sure that our survey would capture those differences. So here are the results of our residential survey findings. 67% of residential providers reported that there were barriers to assisting clients to come and go as they wanted. And the reasons for that, again, weren't because providers were like, I just really don't want to help people come and go as they want. The reasons that they cited were because there was a lack of staff and low reimbursement rates for transportation. And these two themes just came up again and again and again. Additionally, 33% of the consumers of services that we talked to reported not being able to do things like attend church or schedule appointments or visit family and friends when they wanted to. 38% of consumers reported either restrictions or monitoring on the use of their private cell phones and internet use. And 100% of the consumers responded that they were not able to choose the roommate or their roommates depending on, the setup of the setting that we were visiting. 33% of residential settings had policies that restricted when individuals could visit. So these were kind of the things that stood out as potential barriers or problems when we talk about full compliance with the rule. So this all ended up in our report because, again, I think that one of the important things, we all know there's no magic bullets here, and that I think if we do want this to be successful, probably some additional funds will be required. But in order to do that, I think you have to be specific about what the barriers are and how we fix it. And so that's why we did the survey, to be able to say, it's not just about more, give us more money, please, because that's what we need. It's about being able to identify specifically where are the problems and how do we fix them. So after we did that survey and released that report, we thought, well, that's great, but at the time we thought that the rule was going to be in full effect in 2019. That obviously was to change, but at the time we didn't know that. So we got out and about again, looking at more settings, talking to more providers, and trying to gather more information. So these were the results of that first round of visits that were the basis for the report that we published. We have a few copies of the whole report out on the table if you guys are interested or want to see that. So then, for round 2, we did another set of visits, and we continued to monitor Utah's progress towards full implementation of the settings rule. So starting really the beginning of this year, I'm trying to remember if we did any the end of 2016. It's mostly been over the course of this year, 2017. We completed additional visits, once again, to both residential and non-residential sites. But again, for purposes of this session, we visited 12 residential sites this year where we were able to tour the setting, meet with individuals, and speak with staff and consumers again. And so this second round was a little less scientific in the sense that we didn't quite compile the data to give you the 63% and 33% that I was able to give you with our first round. This round was, again, just to say, are there any themes, are there any important pieces that we're missing that if we identify these and come together as a community, that we can work through these barriers. So these are some of the themes that we saw that, again, we thought might pose problems with respect to coming into compliance with the settings rule. So the first was clustered settings. And so I mean a couple of different things by that. We saw some residential settings where there were group homes that were located close to other group homes, so in the same neighborhood, things like that. We also saw some situations where there was a residential setting located very close to, or in some instances, in the very same place as their day setting. And so again, that's going to kind of raise red flags with respect to the rule where people are receiving, all of their services in one place, or where people are really only having an opportunity to interact with other people with disabilities and not, the community at large. So that's what we mean when we say clustered settings. That in some instances there were few opportunities to visit with non-disabled peers. Again, we saw transportation to and from the setting was a theme that came up again in our second round of visits as potentially problematic. We also saw, again, sometimes visitor policies and food policies. So what I mean by this is, visitors only allowed between the hours of 5 and 8, or no visitors after 7 p.m., things like that. With respect to food policies, we would see things like there can be no food in bedrooms, only food at the table, things like that. And again, I think what's important, and I'm sure what some of you are thinking, is that there are very good reasons for some of these restrictions to be in place, right? And we know that and agree with that if there is an assessed need that's documented in the person-centered plan. But sometimes what we have seen is that there wasn't that need, and that policy was applied to everyone. And so it may have been true that there was a very good reason for that restriction to be applied to one individual or two individuals, but maybe not every individual. And so that was problematic with respect to the settings rule. And then also something that was problematic are practices that restrict choice based on staff availability. So what do I mean by that? I mean, in some instances, there were cases where people were given 2 times of day that they could attend to personal hygiene needs, like showering or bathing. And you could say, well, you can take a shower at this time or this time. And obviously we are all restricted. You have to get up and get ready before you go to work, and that has its own time. But in some situations, we were seeing things like people being asked to attend to those needs at 3 o'clock in the afternoon. And if that's what the person wants and that's their preference, that's fine. But if that's what's happening because there's just so many people who need to have those services, then that's when you start to have problems with the settings rule. And the last theme that kind of came up again and again is what we're going to describe as the physical layout that hinders a home-like atmosphere. And so again, what I mean by that is that in some cases, you would walk into a person's apartment or their group home, and it would seem just like anybody else's house. And in some cases, you would walk into a home, and there would be kind of immediate signs that this was, a setting where people with disabilities lived. And so sometimes there would be personal information up on the walls, or kind of a staff office that was the first thing that you saw when you walked in. And I think those sound like little things, and I think the good news is those are, I think for the most part, really easily changed, but I can tell you that they really affect the atmosphere when you walk in and whether or not it feels like a home or not. So I think something that we are trying to do is to, instead of just saying, here are all the problems, to say what are good things, what is a way that we could look at a setting and say, yeah, that's compliant, that's a setting that's doing all of the things that the rule would ask it to do. And so we've come up with these 3 different examples, one of a compliant setting, one of a setting that would need some degree of remediation, and then one that would be non-compliant. And what I can tell you is that for the most part, all of the things on here are kind of compilations. We've taken different things from different places that we've been. I can tell you that out of the settings that I've been to, there were certainly residential settings that were compliant, that were doing all of these things, and so we wanted to make that clear. So what would a compliant setting look like? Well, it would provide support for individuals to pursue personal relationships. We met with one provider who was actually in a rural community, and I have to say, I think I went into that particular setting having, some thoughts about how the services would look, in all honesty, and I was completely wrong and completely surprised, because in that setting, and it was a group home, it wasn't a supported employment setting, they were encouraging people to have personal relationships. There was one individual who was engaged and working on how she would be able to live with her husband when they were married, and that was really exciting to see. A compliant setting would also encourage individuals with disabilities to interact with those without disabilities. Again, this rural setting that I'm thinking of, they had a number of community members who were very familiar with the individuals who lived in the setting, and who would come and go to like rodeos and fairs and all kinds of local activities that were going on. A compliant setting would ensure that individuals have privacy, including the option of locking their door. I know that we've had some I won't say pushback, but questions from providers saying, do I really have to have a lock on the door? And the answer is that, again, without an assessed need or a specific reason why not, yes, people need privacy. I can think of many times in my own life when I really want to be alone, and that if I have to lock the door, then that's what has to happen. A compliant setting assists individuals to direct choices about their lives, including when to attend to personal hygiene needs, how to furnish their room, and who to live with. Again, I think I've already kind of touched on the personal hygiene component and what we were seeing there. And again, being able to decorate your room the way you want to. That's a personal expression that we all have. I happen to be like horrific at decorating, and I always think like, oh no, like this house needs more homey touches, and it does. But at least it reflects my personality and who I am, and that's the opportunity that everyone else should have as well. Also, a compliant setting would support individuals to receive visitors from the community. We went to a couple of settings where there was like a visitor log or a visitor policy, and in a couple of the instances when we signed the visitor log, you could see that there hadn't been visitors for like months or years. And I don't know if that was just a matter of people weren't really being asked to sign the visitor's log consistently, right? Like that could be something that was happening. But if it really has been years since people have been visited, then I think, that I think speaks to whether or not there can be more integration happening there. Last point here is clients' direct choice of individualized schedules and activities. Again, we know this gets at staffing and rates and all of those things that have been discussed. Something that I would say is I know that DSPD has undergone, I think with many of you, work on how rates can be structured differently with respect to non-residential settings. And I think it would be important that same work and thought goes into residential settings as well. Okay, so here is an example of a setting that would require remediation. And again, I know there's a lot of expertise in this room, so please jump in and comment as you have thoughts. I'm sure there are many. A setting that would require some changes in order to be compliant in the context of residential service would be one that might offer pre-planned group activities in the community, but with little opportunity to interact with non-disabled peers. So I think sometimes, if we're talking about something that is great is that we saw people being supported to attend faith-based activities and to get out to church, and that's great. But often, those activities were structured in a segregated way, that they would attend like a special needs mutual or something like that. And so while that's great, we want to encourage people to participate in the faith-based involvement that they want. It would, I think, be great if that wasn't necessarily just to interact with other people with disabilities, right? And that's really, again, what the rule is getting at. So a setting that would require some change would also, an individual might, for the most part, set their own schedule, but then staff would plan, doctor's appointments or haircuts, maybe when all of the other people in the apartment or the group home were having those things done. The setting might have a blanket policy that restricts visitors to certain hours without an assessed need that is documented in the person-centered plan. But then individuals would decorate their own rooms and have locks on their doors. The setting would set meal times and require individuals to eat only in certain places. So again, you can see there's some things here that are going really well and some things that aren't. And I think the thing that was really helpful for me in kind of thinking through these slides was that there's a lot of changes that I don't think do require a lot of additional funding or costs, just kind of a different way in thinking about how services are delivered. And I think so much of the time when we're talking about this rule, it's how can we comply? It's going to cost so much more money. And again, I think that's an important piece. But I also think there are really practical, easy things that could be changed or adjusted that would really, improve somebody's experience receiving services. And then finally, here's an example of what would be a non-compliant setting, a setting that would isolate and therefore be subjected to heightened scrutiny. So a non-compliant setting would be located apart from the broader community. And again, I think that could look a number of different ways. It kind of goes back to that clustered setting that I think we talked about in the beginning. The setting might deliver multiple services on site, or it would be co-located next to again, another setting controlled by the same provider, like a day program or workshop. Portions of the setting might be locked, prohibiting an individual's entrance and exit into certain parts of the home, like, a laundry room or a craft cabinet or any number of things. And again, if there's a specific reason why that's appropriate, that's one thing. If the policy is being applied to everyone, that's something else. Limited community access and difficulty scheduling appointments and visiting with family and friends. If you'll remember back to our first round of visits, about 30-something% of consumers who we spoke with said they did have problems with this point in particular. In a non-compliant setting, individuals are not allowed to lock their doors, again, absent an assessed need, and there would be highly regimented schedules and a lack of choice concerning which services an individual receives. So I think those are the results of what we found when we went out and about and visited with many providers and also consumers. And I also thought it would be helpful, before I turn the time over quickly to Elizabeth, to just say that I think something that's a fair criticism of the Disability Law Center's work, and something that I think whether or not we hear from providers, I think might be thought, is that we only go there for a minute, right? We go and we experience a moment in time, and we don't live with people for days or weeks, and so we don't have the opportunity to see, the range of ways in which an individual is supported to access to the community. And I think that's a fair criticism that we do try to factor in and think about when we talk about these important issues. But I think something that I would say is that in the reverse, a flip side, a perspective that we might have that I think an individual provider might not, is that we do have the opportunity to visit lots of different settings within a similar period of time. And I do think that gives us a perspective that allows us to compare how certain things are working. And so that was really the criteria that we tried to point out today, is that there are places where all these things are working really well and where we think changes can be made to get everybody on the same page. And like I said, I had all kinds of thoughts about how a particular set of services was going to be delivered in a rural area, only to be completely wrong, and to find that this provider was supporting individuals really to live their lives in a way that I feel good about saying is consistent with anyone else for the most part. And I thought that was really encouraging, that it could be done in a location like that, where I would have assumed that it would be really difficult. So I will turn the time over to Elizabeth.
I actually need to go switch the slides over, so I'll be back. If we wanted to discuss sort of what Laura just talked about, or any questions, or sort of raise any points, I think it'd be a fine time to do that now instead of moving into what I'm going to talk about, because it might kind of overlap and we might answer some questions. So if there's any sort of thoughts that people have or questions they have about what she talked about, I think now would be a good time to kind of take a little break for questions.
Question about choice of roommates. It's sort of interesting in my work in the self-advocacy piece, a lot of pretty sophisticated people don't actually realize they have a choice, and I wondered how that is happening in our system.
Sorry, Katie, will you?
Well, you have that one. Is that one on?
Is this one on?
I'm getting no.
Sorry, Katie, you're a busy mic runner. Claire, I think that's a really good and important point. Like I think we said on the first slide, the results from our first round of visits said that 100% of consumers said they didn't get to pick their roommate, and I thought that was a pretty bright line result that we found. Now, again, so what does pick your roommate mean, right? Obviously, that's going to differ and depend on the setting that someone is choosing to move into, and maybe there's only one, room available. But I think that when that person comes to, visit that setting, making clear that you do have a right to live with people who you like or who, don't drive you wild. I can certainly think of several roommates in my past who I would not choose to live with ever again in my life. And those choices are explained to the person who's going to live in the setting. I think that maybe that's a piece that's kind of taken for granted or forgotten, and that doesn't just fall on the providers. Certainly support coordinators would play a big role in informing individuals about that choice and making sure that when they visit different locations, they're considering that, because that's a really important thing. You have to like who you live with. Elizabeth, would you have any additional comments?
Yeah. So the choice of roommate part is kind of an interesting one, especially if somebody's moving into a setting where there's only a bed available in a room. And I think that's part of the person-centered planning process, is like when you're going to visit, does the person understand that this would probably be their roommate? Like if you move into this setting, this is going to be your roommate. Or is the setting that's part of person-centered planning, but also you certainly don't want to put some people have lived together before and it's gone horribly wrong, and so you don't kind of want that person probably to be faced with the choice of only living with this person they've not gone along with in the past. So there's a person-centered planning component. There's also the provider component in terms of if there are kind of difficulties happening, is the person being given an option to, hey, do you want to switch rooms with somebody? Is there's sort of that flexibility component of it is really important when you're considering this part of the rule. And I think it is. I think people would often kind of not always say like, oh yeah, I had a choice of where I got to, who I got to room with, but it is important to kind of make sure the person understands like you could do here, here, or here, and here's who you would be living with, and part of that's the person-centered planning process when they're visiting.
And I also know something that I thought was great is that we did talk to some providers, and maybe everyone does this and it just didn't come up at all of our visits, but about, before somebody made a final choice of moving into a home, about, coming to activities, getting to know the roommates that they would be living with before that final decision was made, so that you could see like, oh, there is going to be a personality problem here, this is going to be a problem before everything is kind of finalized and moved in, or not. And I thought that was a really great thought that was already going on.
I'm a support coordinator, and I have found that those things are happening routinely with providers, but once a person has an argument with someone, then they think they never got a chance to choose. I see that happen repeatedly. Or they have a lease on an apartment, and they were happy right at first, but they have to wait until their lease is up or find someone to buy their lease in order to move. And they think at that point, nobody's letting me choose. Nobody ever let me choose. So I think this is actually happening a lot more than the clients reported.
This is actually changing the subject, so did you want to comment on that, what she said? Sorry.
Oh, no, you're fine. Sure, I'll try to be loud. I mean, I think that was more of a comment than a question, and I'm glad to hear if you know, most folks feel that that's happening. I think as a general rule, I would be wary of discounting the results of consumers, because I do think that sometimes providers think that something has been explained, but that's different from somebody understanding that it has been explained. And again, the rule wants it to be from the experience of the consumer. And I think sometimes, and there's nothing wrong with this, because we're always talking to you know, you all about, like, here's the 10 steps that we need to take. I think sometimes systems are designed in a way that is meant to check boxes to ensure that steps are taken. And there's nothing wrong with that, but I think the rule asks us to go beyond that and to find a way to figure out, did someone understand, you know, the consequences of the choice that they made, and were things really explained to them in a way that they would understand. But again, I take your point, and I'm hopeful that is happening.
This is a clarification question, and I've asked a similar question previously and don't know that I've ever truly understood the answer. Say an individual would like to go get a burrito at 10 o'clock at night, or wants a ride to go visit their family at 9 o'clock when there's very little staff available to go to help them do that. Are there any provisions in this rule that, are there restrictions? Are there anything to try to, you know, help that problem that might exist when it's a difficult, you know, somebody reasonably could decide, you know, I could decide I want to go get a burrito at 10 and I can go do it, but my daughter in a residential setting couldn't on her own. Do you know what I mean? So I'm wondering if that's been addressed.
So I'll also try to do that. I'm pretty good at it. There is a recognition in the rule, or at least in the preamble to the rule. So in the preamble to the rule, that's like, the rule itself is maybe 20 pages long when you print it out, and the preamble to the rule is like 60 pages long. And the preamble to the rule is basically where CMS is responding to comments and questions that are presented to it before it promulgates the final rule itself. And although that question itself is not actually in there, there are questions about, you know, how does that function if somebody, you know, wants to just go and do something and there's not staff available. And it is sort of, they do recognize that some things are a function of planning. Like, somebody may not always be able to go immediately, but there should be a way in which a person's needs and desires to go do something can be met in a reasonable amount of time. In terms of, you know, maybe somebody can't go get a burrito at 11 p.m., but they can go get a burrito tomorrow for lunch. So that sort of meets the person's needs and desires and choices. And there are other ways to make sure that there is a degree of like kind of spontaneity that a person can not always have everything scheduled. That's really, really important, to not always be like, oh, well, you have to wait until tomorrow at 5 to go do that. So there is a sense of responsibility of the provider to meet some degree of, okay, like, let's go do this, but it's not like a provider has to always be at the beck and call to go do everything immediately. There is a little bit of kind of recognition that that's not always going to be possible, but it also shouldn't be true that the person never gets to do anything, kind of, at least semi-spur of the moment, like, okay, we can go get a burrito in 30 minutes, because that's when we're done with this thing. So it recognizes that you can't do everything all the time, but the purpose is to make sure that a person is getting to choose to do the things they want to do, and not just what everybody else is doing.
And I would just add that I think, and the answer is certainly not, you're going to wait to get a burrito until Thursday at 5, like Elizabeth said, because Thursdays are the days that we get burritos. You know, I think sometimes there's a little bit of that's built into the choice of activity that folks have, and I think that is what the rule is trying to steer clear from.
Sorry, Katie.
I'm interested in the enforcement piece. So when you did this survey, other than just being able to strongly encourage someone to change their policy with respect to locking doors or choosing or allowing people to choose their own roommate, did you have any enforcement authority? I know you're not Department of Justice, but where does the enforcement piece come in?
So as I explained sort of briefly and hurriedly earlier this morning, the rule, the only pieces of the rule are currently kind of supposed to be enacted. And so, for instance, person-centered planning is currently supposed to meet the rule, but the requirements of the settings to meet the home and community-based characteristics is part of the state transition plan. And so the settings themselves are currently supposed to be moving towards compliance, but they don't actually have to, the state does not have to assure that all of the settings in the HCBS system are compliant until 2022. So, even if, Laura could sort of file a lawsuit about Olmsted, but she couldn't necessarily say that you are not complying with the rules you should be complying with right now, because the state has until 2022 to move into full compliance with that piece of the rule itself. But the whole point is to not wait until the end. States are being highly encouraged that they should be really moving towards it now, because they need to be able to tell the federal government in March 2022 that everything is good and all the providers who have had compliance plans have met those compliance plans, and that has been verified. And so we can, the state can say, we can stand right now and say that we know all of our system is compliant. So.
And I would just add that, there was this kind of unexpected delay wherein at first we thought that all of this, the kind of drop dead deadline was going to be 2019, and now it's 2022. And I think that delay is actually really good, because I think that I would have had concerns about our state's readiness at 2019. And so I think that the good news is that there's more time to kind of work through some of these problems. But I do also think that makes it then incumbent upon all of us to take this process really seriously and to make sure that we're ready by 2022. Any more questions? All right.
We recognize it's getting a little toasty in here.
Do you guys have an open door right now? I'm seeing a lot of waving.
This microphone's not seeing. So I'm going to skip a few of the slides that are in here, so bear with me when I kind of figure out what we've already talked about and what we haven't. And that's probably most of the very beginning, so let's just maybe move through here real quick. So the way I structured kind of what I had planned to talk about was looking at, we need to understand what the rule says, which I think we all understand from between this morning and Laura's presentation. I set forth a lot of the pieces of information that exist in current CMS guidance, because there are a lot of questions about what a setting is supposed to look like. And there's a lot of guidance out there, and it takes a little kind of culling through all of that guidance to find, there's actually a lot of information out there. I just have to kind of put it together. So hopefully I've done a little bit of that for you all. And as Laura's talked previously, there is a function to the person-centered planning process, but at the same time, the person-centered planning process is not some magical thing that will just say, we can keep doing what we were doing, we just have to justify it in the plan. And that's kind of, it is not a magical elixir to solve compliance issues. And as we've already talked about, just always keep in mind that the focus of this rule is on the outcome, what the person experiences, and that the comparator is not whether it's better than it was before, but is the person having the same degree of access as individuals not receiving Medicaid HCBS in the community. So that's what you're always sort of supposed to keep in mind as what the minimum is. And it's not really about meeting a minimum. but kind of structuring, the setting is supposed to be structured to maximize opportunities for an individual, and it's not sort of saying like, okay, well, we went out 4 times this week, that's enough, that's the minimum. And actually, I did want to say this rule went through several variations, and at one time it was structured more to have like a minimum and a kind of numerical standards. And after rounds and rounds of comments and years of development, what CMS came up with was not about minimums, but about the individual's experience and taking it from that perspective. So I think that's important to remember, is that not only did this go through a lot of commenting and a lot of voices were heard, but where they finally landed was more about the individual's experience, because I think that aligns with the obligations under Olmstead, but also is a better measurement than just sort of meeting a bare minimum. I am going to skip this one because I think we've covered most of this already. And I also wanted to highlight the one at the bottom about a person choosing a setting does not automatically make it HCBS. We covered that a little bit earlier, but that's important to remember. It's kind of irrelevant to the determination of whether or not the setting itself is providing a true community experience for that individual. We also covered this one. Oops, keep moving. And these. And let's go back. Yeah. And I talked about private homes this morning already, so I won't belabor this point, but as I said this morning, the state is still expected to confirm that homes that are private homes are meeting the expectations of the rule. And one of the things the state is supposed to do is look at private homes to ensure that they are not purchased or established in a manner that isolates the individual from a community of individuals not receiving Medicaid-funded services. And so what this is talking about is maybe like when parents get together and purchase a home and set up sort of a particular type of setting, and then enforce rules that may make it look more like an institutional setting. So this is, or like a family buys a home and one person, their adult child lives there, and they have leased other rooms out to other individuals. Just because it's a private home of that individual doesn't necessarily make it exempt from the rule, because nothing's exempt from the rule. And we covered this one as well. One of the things to keep in mind, this is when we're talking about, the rule talks about presumed institutional settings, and it covers some of the characteristics of what makes something presumed institutional. And I think those are good things to keep in mind when you're considering whether or not a setting has community-based characteristics. So as Laura pointed out earlier, settings where multiple types of services are provided on site can be something that's presumed to be institutional as a characteristic. And also something like use of restricted interventions. So if someone has is restrained a lot, or they have a isolation room and it's locked, and all of those things that are characteristics of institutional living, that can make a setting to be presumed institutional, and it could make it non-HCBS. And these are also, when you look at, this is what I'm talking about when you're talking about guidance, tells you a lot about what is community and not. Because when you're looking at what CMS says is in a setting that isolates individuals, which is a setting that does not typically meet the rule, we're talking about gated and secured communities. So is there a fence around the property that is locked? Are the rooms or the building, is it locked to prevent people from escaping or running away? Are there multiple group homes co-located near one another? Especially, are there staffing sharing between the group homes? Is there one transportation van? Are they really functioning like one larger facility that is more institutional than community and needs to be something that's addressed? The big one is, of course, are there daily activities and non-HCBS services that are taking place on site? So is a person being brought in to give haircuts, or is the doctor being brought in rather than the person going out into the community to go to those types of appointments? And of course, the one that always is a big harbinger of whether it's community or institutional is are the individuals going out into the community, or is the community coming into them? Because if the community is just coming into them, that is called reverse integration and is not going to meet the needs of the rule. It has to be a scenario where the individuals are going out and about into their own community and having interactions that are not just in large group activities. So as Laura mentioned before, the rule applies kind of almost individually to each person. So the setting rules have to be met for every single person in the setting. If there's a restriction, it can't just be a broad restriction on everybody who lives there because they all have a developmental disability. It is about every single person and what their experience is like. And so in this guidance, what CMS is talking about, okay, what does the setting have to prove to the federal government to pass the heightened scrutiny test? And one of the big things is, what is the proximity to resources, activities, transportation? What are the schedules of the individuals? Are they based on their individual interests, or are they all just provider organized? And whether or not people with disabilities consider the setting to be people without disabilities consider the setting to be kind of just part of the community, or is it, oh, that's the place that serves people with disabilities, we don't go there. And those are all kind of considerations to think about when you're saying, is my setting really compliant or not? I'm like really hot. So the other pieces of heightened scrutiny that are important and I think relevant is that the state or the individual setting has to show that the individual participates in typical community life, that they are not just doing the activities of the provider. And you see a theme, like these same themes keep running through all of the different guidance. It's all about whether or not the individuals are having an opportunity to have a say in what they're doing, and whether or not it's just about what the group decides. And so you're saying, like, okay, how do I put that into practice? You can have, you may say, okay, everybody gets together and we decide like what we're gonna do. That can't always be the case, because usually somebody's gonna like lose out, because maybe John likes to go bowling and his other housemates hate bowling, so the house never goes bowling. That's not ensuring that that John's interests and needs are being met. So there has to be a degree of making sure that each individual's needs and wants and choices are being met by the setting. And also that, maybe John gets to go bowling by himself. He's not supposed to go everywhere with everybody he lives with. That's a key piece of the rule as well. There are CMS exploratory questions. These are questions that were created early on, and they are good questions to look at and to sort of self-judge about whether or not you're really meeting the criteria of the rule. And the questions are just that, they're just questions. But I think it's pretty clear from the questions what CMS's expectation is and how the rule is supposed to be implemented. One of the things that, these are some of the selection. This is about 5 pages of questions when you look at it from the CMS website. So I just kind of picked a few that I think are most relevant to this question about the pitfalls that providers may fall into when trying to implement residential settings. And I know a big one is the one about, does the individual come and go anytime? Are there allowances for visitors, that type of thing. And that was actually really well discussed in the preamble to the rule, the part about visitors. There were a lot of concerns about, well, how do I let visitors come all the time? What about the safety of other residents? What about the right of quiet enjoyment that other residents have from visitors? And the way the CMS sort of answered that question in the preamble was, there may be sort of rules that the residents decide to in fact about how they choose to handle visitors. But the key is it's not the setting itself saying, well, the only visiting hours are 5 to 7. There has to be the presumption that you can have visitors at any time, and if everybody in the house says, well, we want quiet time from 11 to 6, that may mean that the visitor has to remain quiet, but you can still have a visitor. There are sort of rules that the housemates can kind of come up with, but the key is that the setting itself cannot kind of make the rules for its own ease and enjoyment. The presumption is that visitors will be allowed. There was also some question about how long can visitors stay, and there was not an exact answer to that, but there was sort of a, there are lease provisions, and y'all are really messing with my eyeballs with the lights on and off. So I think that if you have some questions, I'm not telling you to go read the entirety of the preamble to the rule, but you can do a find Control F in the rule and find the word visitor, and you will find a whole section where they discuss what their expectations are regarding visitors. And the last one is one I think is really important, that staff communicates with individuals in a dignified manner. And that's kind of a very broad term, but one of the things that CMS was concerned about was that in an institutional environment, typically individuals may not be called by their name. They may be called by honey and sweetie, or they may sort of be treated in a very paternalistic manner, as opposed to kind of as an individual with their own rights. And that's not true of all institutions. I'm not trying to make a generalization there, but one of the things that the rule was sort of addressing is that if an individual is living in their own home in a residential setting, they should have a degree of independence and autonomy and be treated kind of as just a resident and a roommate, as opposed to somebody who's being cared for and have a degree of kind of respect and that type of thing. So they really were paying attention to whether or not staff is saying, not using individuals' names or just referring to them as referring to the residents in a way that's not super recognizing the individual's rights. So these are kind of when we go through everything in the rule and the guidance and all those things, some major questions to consider are the lighting has really just messed with my concentration. So when I went through all the guidance, I kind of pulled out the major questions to consider when you're thinking about whether or not my setting meets the requirements of the rule. So you've heard this again and again, but how do residents participate in the community? Who decides it? Are they group activities? Are they disability-specific activities? So like Laura mentioned, are you only going to your church-funded, church-organized activities, or are you going elsewhere? And also, are the activities that the person's doing, do they reflect the needs and wants of the individual residents? So like, is John going bowling while Sally goes to the movie theater? Or are they both having to go to the movie theater one week and go to bowling the next week, and one of them hates the other week? Also, is there private or public information in a setting? So, as Laura mentioned, are there posted medication charts? Are there posted appointments? Is there a calendar where everybody's informed of where John is and where Sally is, and whether or not John is at his psychiatrist appointment, or that type of information? Really protecting the privacy and the autonomy of the individual is really important. Also, it's a HIPAA question as well, so you should be aware of that one. But that type of calendar is typical more in an institutional setting where you have a big board with everybody's name on it, or a number to represent everybody. A home might have a family calendar, but it's not necessarily going to have everybody's really private information on it. And also the level of privacy is, are you providing services in a way that the person, say for instance, are showers provided, and shower's a bad example, does the person have to get dressed in front of their roommate? Because that's the easiest way for the staff to say, okay, let's get dressed, and the person goes into the room with the two roommates and kind of like helps them alternatively get dressed. That's not necessarily a level of privacy that respects the individual autonomy. So think about the level of privacy that's offered. A big one too, and Laura mentioned this in their survey, is how are phones and computers, spaces for visitors, policies for visitors, what does that all look like? And is it look more like a home, or does it look like a more institutional setting? Are there a lot of restrictions? Are those restrictions actually made pursuant to the person-centered planning process, or are they just for the convenience of staff or for the convenience of other residents? And I'm actually going to stop there because I think we're running out of time. The lights just totally threw us all off.
The panel is behind the ASL interpreter, so it might be.
Oh. Now we know whose fault it is that it's 105 degrees in here. Just because you're wearing red does not mean I need to turn red. So in person-centered planning, I do encourage everybody, if you have not looked at the guidance from CMS on wandering, I think the guidance from CMS, although it's a lot about wandering and sort of tailored to individuals with dementia or other memory-related issues, the guidance on wandering and the training that they did on wandering is very applicable to individuals with IDDD who have elopement potential issues or other kind of dangers associated with like the equivalent of wandering. And there's some really good information in that training and in that guidance about the expectation for when kind of rights can be curtailed because of safety issues. I also wanted to skip ahead to the role of risk, because I know this is a big deal and people talk about it a lot. And it's really important that there's a difference between risk and safety. CMS has long recognized, even when there's a letter from 1997, that CMS says, we believe an individual has the right to assume risk, commensurate with the person's ability and willingness to assume responsibility for the consequences of that risk. The person-centered planning process talks a lot about allowing people a level of risk that does not endanger their health and safety, but allows them to sort of make choices and make some mistakes that is not necessarily going to, get them hit by a car, but is going to allow them to make a few mistakes. And risk is really important. It's part of being a human being, and it is also part of being out in the community. So you cannot limit freedoms on a class of group or individuals, such as house rules. And just because you may serve a lot of people who are the same kind of disabilities, they're still different people and they have different abilities and different choices, and so it still has to be very individualized, and you can't just have a rule in place for convenience. So one of the rule recognized there may have to be a cultural shift a little bit from a focus on protection to a focus on sort of encouraging people to live in the community and have access to everything the community has to offer. So I'm going to stop there because we're out of time. Oh, we're pretty close to it. We have 3 minutes if there's any last minute questions other than why is it so hot?
Mine's more of a comment. I can just talk loud. I think all of this is awesome, but I deal with a really severely affected individual with autism. And I think part of this plan should be educating the community, because the community is not always so willing to take our kids on or our adults on or whatever, to employ them, to have them be at their functions or their stores or whatever. So part of it, I feel like, should be educating the community in this inclusion.
And I don't disagree that that's a big part of it. And I think that if people are being denied access to an event or a service, and there's a lack of kind of understanding that these are the accommodations the entity has to make, that's a whole other ADA issue that is a violation of that right. But I think there's a lot of kind of community education, and this is, as I said this morning, it's a continuation of integration of people with disabilities into the community. And just as it was however many years ago when more and more people were moving out of institutions, there was a bit of a period of community adjustment. And I think this is another one of those kind of recognizable periods of community adjustment where people are like, oh, wait, there really are people with disabilities who should be included in this, and this is how we do it, and this is how we make that function. So I think there is a bit of a learning curve.
And I would just echo, I think that's a really good point. I have a family member, I have a brother, an adult brother who has autism, and, you know, I have so many memories growing up where my family would try to go someplace and we ran into all kinds of problems where I felt like we weren't welcome. And so I think that that is something that's important to talk about and that's important to address. And certainly the Disability Law Center, we do try to do work with respect to employment discrimination, discrimination in public accommodations. But I also think it's important to give the community the opportunity to do better. And I think in order for the community to have that opportunity, we have to be out and about, even though that is hard. And I don't want to diminish that in any way, because I know that's the case.
Any other questions?
Well, thank you for suffering through the light fiasco of 2017, and also the temperature fiasco. No worries. As you can see, things happen. Sometimes your best efforts to be integrative need some tweaking, but we appreciate your time, and go leave the room and take a break, and we'll try to get this sorted out for the next session.